Hello everybody, thank you for joining my presentation. My name is Jared O'Connor, and today we will be discussing public health promotion through a chronic disease epidemiology perspective. We will be focusing on three chronic diseases: obesity, diabetes, and cardiovascular disease. Obesity is characterized by an individual having body mass index of 30 or greater, which can lead to many chronic conditions and health risks. Between 2021 and 2023, the adult obesity prevalence in the United States was 40.3%, or about 70 million. Figure 1 below represents this obesity prevalence by sex and age. There is no significant difference between men and women. However, we can see disproportionately higher rates of obesity among those between 40 and 59 years old. Between 2017 and 2020, the prevalence of adolescent obesity in the United States was 19.7%, or 14.7 million. On the other hand, diabetes can be defined as a chronic condition that occurs when blood glucose is too high, resulting in higher risk for other health problems such as cardiovascular disease, stroke, and kidney failure. In 2021, the prevalence of the United States population living with diabetes was 11.6%, or 38.4 million. During this year, the incidence of newly diagnosed adults was 1.2 million, or 5.9 per 1,000 people. It is important to note in 2021, 97.6 million adults had prediabetes, having elevated blood sugar levels, but not high enough to be formally diagnosed with type 2 diabetes. This figure on the bottom right represents the estimated prevalence of adult diabetes in the US by diagnosed, undiagnosed, and the total amount. While the total adult diabetes percentage was 14.7%, 3.4% of this population, or 8.7 million, were undiagnosed. This means they met laboratory criteria for diabetes, but were not aware or did not report a diabetes diagnosis. A specific demographic with disproportionate rates of obesity and diabetes in this country is the rural population. Although only 19% of the U.S. population resides in rural areas, these communities occupy 97% of the country's landmass, highlighting the vast remoteness of many regions. So starting with obesity, a cross-sectional study published in 2018 examined behavioral risk factor surveillance system data to assess obesity prevalence among rural adults in the United States and compare those to their urban counterparts. Key findings reveal a higher obesity prevalence in rural areas compared to urban ones. Obesity rates in rural counties had a prevalence of 34.2% compared to 28.7% in urban ones. And while both of these numbers are less than the prevalence described in the previous slide, this represents the ever-growing public health issue of rising obesity and chronic disease prevalence. Shifting to diabetes, another cross-sectional study, also utilizing data from the behavioral risk factor surveillance system, examined diabetes prevalence across 41 states in the U.S. Findings revealed diabetes prevalence was greater in rural areas at 14.3%, compared to urban ones at 11.2%. In rural areas, prevalence ranged from as little as 8.4% in Colorado to as great as 21.3% in North Carolina, while urban prevalence ranged from 6.9% in Colorado to 15.5% in West Virginia. Both of these studies suggest there is a significant relationship between urban-rural status and obesity and diabetes. As demonstrated in the two previous research articles, the authors highlight significant social determinants of health that contribute to the higher obesity and diabetes prevalence in rural America. Beginning with healthcare access, rural populations often face limited access to healthcare providers, especially specialized care. With fewer healthcare options, individuals are faced with having to travel long distances to receive care, which many turn away from doing. Health insurance costs also tend to be higher, and options are much less compared to urban ones. Higher poverty and lower education rates also contribute to these disproportionate chronic disease prevalences, highlighting differences in socioeconomic status. Food insecurity and access to affordable, nutritious foods is seen to be more challenging in rural America. Populations in these areas may be more prone to food deserts, which encourage people to turn to unhealthy and calorie-dense foods. Lastly, the built environment can have implications on obesity and diabetes prevalence. While the previous determinants are heavily influenced by the built environment and its resources, additional factors include lack of infrastructure that encourages healthy behaviors and physical activity, or transportation barriers that restrict the same things. Three separate structural challenges can be highlighted from the differing rural and urban chronic disease rates. In both research publications, the authors highlight the lack of and future need for health policy to address this large divide. While there are current policies in place to address the obesity and diabetes epidemics across the country, many suggest these programs do not tailor towards rural communities and their contexts. Next, healthcare availability is not as widespread in rural communities, leaving many without the preventative or management care they need. Like food deserts, many areas across this country are facing newly called healthcare deserts. The third structural challenge seen is with the collection of public health data for research, intervention design, and policy intervention. Due to a minority amount of the country's population encompassing a significant majority of land, some areas lack surveillance systems and data reporting, which can hinder the true significance of its prevalence. For example, the research comparing rural and urban diabetes prevalence only used 41 states for their analysis because rural data was lacking in 9 other states. Research and surveillance data can highlight trends in health behaviors frequently expressed by rural America, which are problematic for both obesity and diabetes. These trends are influenced by both social and structural factors previously discussed. Beginning with obesity, 3 of the many known behavioral risk factors for this condition include diet, physical activity, and tobacco use. Trends reveal rural adults are less likely to consume 5 or more daily servings of fruits and vegetables compared to non-rural adults. These same rural populations are less likely to engage in high-intensity levels of physical activity. Lastly, there is a large gap in tobacco use among these populations. While 19.2% of rural adults smoke cigarettes, only 14.4% of their urban counterparts do. Shifting to behavior trends that are problematic for diabetes prevalence in rural areas, 3 additional ones on top of the 3 just described include food insecurity, utilization of preventative and management health services, and difficulty with medication adherence. When it comes to diet, not only are the dietary patterns risk factors for this chronic disease in rural communities, but the options or lack of contribute as well. Food deserts limit access to healthy foods, making individuals turn to consume highly processed and unhealthy foods and beverages. Research has also seen correlations between rural adults and limited utilization of health services, where this population is less likely to receive diabetic screenings or management care. In addition to this management care, diabetes medication adherence is more challenging in the rural setting due to factors such as healthcare infrastructure issues. These same behavioral risk factors are prevalent throughout the rest of the United States and can see both positive and negative trends throughout recent decades. Analyzing trends such as these are important to appreciate how far public health has come, but also reminding there's still much work to do. One study compared national health behavior trends in obesity from 1999 to 2020. Improvements included diet quality, physical activity, and tobacco use. We have seen increased adherences of adults partaking in a healthy diet and sufficient physical activity, and a decrease in adults who have never smoked. However, setbacks we've seen related to BMI have existed in recent decades. The prevalence of adults with a healthy weight has decreased 8.5%, and the rate of adults with severe obesity has increased 2%. Similar improvements and setbacks in health behaviors can also be seen nationally in terms of diabetes. Between 2007 and 2018, adults living with diabetes have reported greater trends in health behaviors. This population has seen an increase in tobacco avoidance, a decrease in alcohol consumption, and they have been sleeping more. But still, setbacks are seen in diabetes care and dietary patterns across the country. 4.5% of adults have undiagnosed diabetes, highlighting those systemic issues and lack of screening previously discussed. Additionally, the prevalence of adults with diabetes adhering to daily added sugar recommendations has decreased 7%. So now we will transition into downstream chronic diseases, specifically cardiovascular disease. Midstream chronic conditions such as diabetes and obesity are risk factors for subsequent diseases. Cardiovascular disease is a broad range of conditions that affect the heart and body's blood vessels. Year after year, this is the leading cause of death in the United States. In 2022, 1 in 5 deaths were due to cardiovascular disease. Looking at some of the most prevalent cardiovascular diseases, you can see an estimated 7% of adults aged 20 and over have coronary artery disease, 33% have hypertension, 5.7 million with congestive heart failure, and 7 million have had a stroke during their life. Examining the figure on the left, we can see heart disease rates are exceptionally high in the southern and Midwest regions of the country. Both obesity and diabetes are significant risk factors for the development of cardiovascular disease. In addition to this, rates of cardiovascular diseases among those with either obesity or diabetes are significant, highlighting how midstream chronic conditions influence downstream chronic diseases. To demonstrate this, we have extensive cohort studies, such as the Framingham Heart Study, which revealed individuals with a higher BMI or diagnosed diabetes were found to have an increased risk of developing cardiovascular disease. In cases such as diabetes, the risk of CVD increased 2 to 4-fold. Because multiple health conditions and events can be put within the cardiovascular disease category, it allows for many ways to analyze its prevalence and incidence in rural America. So looking at the figure below on the left, we can see heart disease mortality rates in urban and rural America from 2 time points. In 1999, the rural death rate was 280.1 per 100,000 and 189.1 per 100,000 later in 2019. Although this is a significant decrease at 32%, you can see not only is the urban death rate lower for both time points, but has a greater percentage decrease rate at almost 41%. Examining incidence generally, between 2010 and 2022, over 2.1 million deaths in rural America were related to cardiovascular disease. And within 2022, 435 per 100,000 people in rural America died to this condition. To gain a greater understanding of the burden of cardiovascular disease among rural populations in the United States, let's discuss a study recently published. A cross-sectional study titled Cardiovascular Health Among Rural and Urban U.S. Adults, Healthcare, Lifestyle, and Social Factors analyzed 27,000 adults through a dataset collected in 2022. Their findings showed rural adults were more likely to smoke, be insufficiently physically active, and have greater social risk factors, all which align with the previous social determinants discussed. In addition, they found rural adults exhibit significantly higher hypertension and coronary heart disease rates compared to their urban counterparts. This same study also identified various structural challenges that increase the risk and leads to worse outcomes regarding cardiovascular diseases. When they adjusted for social risk factors such as poverty, education level, food insecurity, and home ownership, it attenuated the rural-urban disparities in hypertension, diabetes, and heart disease. This highlights the need to improve these socioeconomic conditions across rural communities. Similar to obesity and diabetes prevalence in these areas, limiting factors in healthcare access, public health surveillance, food access, the built environment, health literacy, healthcare insurance, and poverty disproportionately impacted rural America. All these challenges increase the risk factors for cardiovascular disease and impact the higher incidence and mortality rates this population is seeing. Along the lines of risk factors, similar behavioral actions that increase the risk for obesity and diabetes are same for various cardiovascular diseases. These include poor diet, physical inactivity, tobacco and alcohol use, chronic stress, and poor sleep. The similarities between behavioral risk factors and these chronic conditions highlight the interconnectedness of lifestyle-related diseases and their risk factors. So when an individual is at risk for one chronic disease, they are likely at risk for many others. Being the leading cause of mortality in the United States, cardiovascular disease carries significant economic implications. This can be broken down into either direct or indirect costs. So beginning with direct costs, these are the expenses directly related to the disease, diagnosing, treating, and managing the condition. In 2022, the American Heart Association calculated $400 billion were spent directly on cardiovascular disease that year. What is even more surprising is just how much this number increases year after year. In 25 years, that number is projected to quadruple to $1.34 trillion. As we have seen in recent decades, public health improvements have allowed people to live longer and healthier lives. However, this results in aging populations and increased prevalence of chronic diseases, such as cardiovascular disease. On the other hand, indirect healthcare costs are not as visibly seen, but are still significant. These are the non-medical costs as a result from the health condition. Examples include time and money in lost production, premature death, or the time and economic burden from family and caregivers. In 2022, the indirect cost that resulted from cardiovascular disease was $234 billion, or $643 million a day. This is also expected to rise in 2050 to an estimated cost of $361 billion. So through this analysis and research conducted, I urge you to take away the following 3 items. Acknowledging this will allow us to better understand possible solutions and how we can collaborate to solve these issues. So first, chronic diseases such as obesity, diabetes, and cardiovascular disease are widespread across the United States, but the burden disproportionately impacts certain demographic groups, such as those living in rural areas. Second, in these communities, overlapping social determinants of health and structural challenges exist, contributing to higher disease prevalence. And finally, these same factors also influence individual health behavior, leading to further risk of developing these chronic conditions. So with these 3 takeaways in mind, we can transform what we know into actionable solutions that better lives in the way of prevention, early detection, and treatment of these chronic diseases. In order to do this, collaboration is needed among all stakeholders in this sector. Just to name a few, these include public health professionals, policymakers, legislators, and most importantly, community members from this rural population. An emphasis should be made on solutions that target behavioral and modifiable risk factors, which is where lifestyle medicine comes into play. Lifestyle medicine utilizes 6 different pillars of medicine, which all play a significant role in promoting health and well-being. So these 6 pillars include healthy eating, physical activity, sleep, social connections, avoidance of risky substances, and stress management. Integrating lifestyle medicine can be done through the context of policy, education, and in healthcare systems. In order to further integrate lifestyle medicine in rural communities, it is important to address social determinants of health and structural challenges. Addressing these limitations, such as food insecurity, the built environment, healthcare access, can be done through the work of policy. As discussed earlier, several chronic diseases policies exist across the country but lack focus on rural communities. Expanding policy through a rural lens can allow for changes in the built environment that address challenges that limit the health and well-being of communities within this demographic. So just a few examples include incentives for local food systems, funding to improve infrastructure to allow for physical activity, telehealth expansion, public transportation, and health educations to teach about lifestyle medicine. So thank you for taking the time to listen to my presentation today, and if you have any questions, please feel free to reach out to me. Thank you.